Happy Friday, everyone. Welcome back. We're so pleased to have Dr. Ryan Demmer speak with us today. A few quick announcements before we start. First, next week's seminar is with Lauren Gilchrist, an alum of our maternal and child health program. And she'll be speaking about the future of reproductive rights in and around Minnesota. During today's lecture, we will be providing in the chat box a link to a place where you can ask anonymous questions of Lauren. Lauren and I will be speaking next week, and she wants to make sure that she's addressed your questions going into the seminar, as well as the questions that may arise during the seminar. So please do feel free to ask questions via that link that we'll provide. The following week's seminar is going to be joint and co-sponsored with a Division of Health Policy and Management, so our friends from across the river. Joe Gogler will be speaking about his trials and tribulations as an aging researcher in aging studies. And so we're actually so thrilled to be able to co-host an event with the other division. We'll be holding it in this space at this time, so they are actually accommodating our schedule. I also wanted to make another announcement about what would have been today. So originally, if you've been watching the seminar series schedule, you will have noticed that today was going to be the Martinson lecture. And I just wanted to pay a little tribute to Dr. Carl Martinson, whose family has been incredibly generous to our division and who funds an annual, and this would have been the 17th annual Martinson lecture. It is a lecture recognizing Dr. Martinson, who was a colleague of the individuals who started the Division of Epidemiology and Community Health, who was a physician in the Twin Cities. And he and his family have been dedicated to providing resources for us in the division, including the seminar series, as well as scholarships, awards to international students in our division. So we are incredibly thankful to the Martinson family. The hopes, from what I understand from Dr. Lupker, is that we hope to have, as scheduled, in person, Dr. Chesney come and speak to us in 2022. We'll see how that goes. In the interim, I know that Dr. Lupker is also working with the Martinson family on having a webinar on a different topic. So fingers crossed that we'll be able to honor Dr. Carl Martinson and his generosity to the division either later this year and hopefully in person next year as well. So Dr. Demmer, I will tell you, I'm very grateful to Dr. Demmer because he did fill this empty spot, what would have been the Martinson lecture slot. And I'm also incredibly grateful because I just viewed the seminar recording list, and the seminar that Dr. Osterholm and Dr. Demmer had at the beginning of this fall semester has had more than 10,200 views and only a couple hundred hateful comments. So we know that this is something that's very important to us at the school as well as us in the community. So thank you, Ryan, for taking this empty spot. Ryan was actually trained here all the way from his undergraduate degree, which he designed to include public health because we didn't have an undergraduate degree, and we still don't have an undergraduate degree in public health, through his Master's of Public Health and his doctoral training in epidemiology. So he is an alum 3 times over and a Gopher fan. After he graduated with his PhD, he went on to Columbia, in which he was a postdoc there as well as junior faculty. In 2010, we were, in 2017, we were also happy to have Ryan back with us as faculty. He's currently an associate professor of epidemiology with tenure. With regards to his current work on COVID, Ryan's focused on the interface between infectious disease and chronic diseases. In non-COVID times, Ryan's research focuses on the understanding of the emerging role of the human microbiome, in addition to the progression of cardiometabolic diseases, including diabetes and heart disease. In the context of COVID-19, he's been leading efforts to better understand asymptomatic transmission and the public health burden of long COVID. Early in the pandemic, he initiated a cohort of healthcare workers to inform the prevalence of COVID infection among asymptomatic healthcare workers. The study is still ongoing, and he has expanded into a family study assessing infection burden among families of healthcare workers. Regarding long COVID, he is collaborating in a national consortium across 30 institutions involving more than 50,000 participants to better understand who's at risk for becoming infected, as well as going on to develop chronic disability secondary to initial COVID. So thank you very much, Ryan. I'm going to leave it to you now.
Thank you, Dr. Nguyen. It's a pleasure to be here. And thank you to everyone for tuning in this morning for this particular seminar. I'm looking forward to the discussion conversation that will ensue afterwards. As is typical in the seminar, my goal is to try and be done by around 10:40-ish, give us some time to go through Q&A and just more general discussion. So with that, let me just get my screen set up, shared, Zoom controls organized. So today I'm going to talk a little bit about a healthcare worker study that I've presented here before. I'm not going to go into much of the background and the details, and this part of the presentation will be more brief. We've expanded that to a family study, and I want to share some seroprevalence results that we have that I find to be fairly interesting. And then we'll move on and talk more about the University of Minnesota COVID vaccination mandate and a survey that we were able to put together around the time that the mandate came out. Try and get some baseline insights as to what our vaccination rates actually are on campus and across the system, and what this means for the future in terms of vaccination at the University of Minnesota. I want to start real quickly with a poll. So you should be able to see a poll on the screen now. Jeff, give me a heads up if you're not seeing that. If people want to just quickly chime in and respond to that, it'd be great. All right, I'll give it 2 or 3 more seconds. We're over 80% response rate. Should be able to see the results now. So in terms of knowing somebody who has been infected with COVID, basically everybody, 98% know somebody who's been infected. And I think of high relevance to today's part of today's conversation is, do you know somebody who has not received a COVID-19 vaccine? And almost 8 in 10 people do know somebody in that camp. And I think I'm not surprised by this, despite the fact that vaccination rates are reasonably high. Not quite as high as we'd like them to be, but still reasonably high for a new vaccine. Most of us know somebody who's not comfortable with the vaccine yet. And I think it's incumbent upon us all to be a bit more conversant and have the ability to have conversations with people who are not vaccinated and meet them where they're at and understand where that's coming from. And then I was just sort of curious about how rapidly booster shots were being taken up, because they've only been recently approved. Looks like 3 out of 4 people know somebody who has received the booster shot already. Okay. So I already talked a little bit about the outline. This is where we're going today. Some quick acknowledgements up front. A large number of people, particularly for the healthcare worker study, have been involved since the beginning as it's evolved through many different designs and stages and goals. So thank you to everyone, and particularly right now, working very closely with me on the healthcare worker study is Bruno Bahn and Grace Pankratz and Angie Elric. We meet on a weekly basis, and their insights and guidance and dedicated work involved in this study has been really essential to getting it to where it's at. And then, of course, I'm very appreciative to a number of different funders who have contributed to keep that study going. So in terms of the healthcare worker study, I wanted to share a little bit on a newer and more recent phase that we've entered since last December, which is looking at seroprevalence. And this was started with funding from joint funding from MDH and Centers for Disease Control. And effectively what we're doing is shipping kits to not only healthcare workers, but we've also now expanded it to include household adults and children in the household. So we can get some sort of estimation of infection rates, at least recent infection rates, even among kids in these particular households. And they receive one of these kits that you can see displayed here. This is what it looks like. It's a little clamshell with kind of a cotton ball type tip. And you prick your finger with a lancet that is provided, and the blood is just absorbed into this tip. It's very similar to a dried blood spot method with a few advantages. It's quick, it's simple, and people are able to do it remarkably well with high success rates. That's the method we're using. And then we have an antibody assay developed by Quansis Biosciences. It's an IgG targeting the spike protein. It's EUA approved for the spike protein aspect of it, with pretty decent sensitivity and specificity. This gives a little bit of information about positive predictive values, or excuse me, false positive rates based on different levels of prevalence in the background population. And the background prevalence of infection at this point in time is now much higher than 5 or 10%. So false positive rates are likely to be quite low. Part of this kit more recently has been developed to also include results about reactivity to nucleocapsid protein, which allows us to get at some interesting information. And I'm going to say a bit more about that in this slide. So the value right now of having a test that can look at reactivity to both spike protein and nucleocapsid is that vaccines are designed to elicit antibody response to spike protein. So in the context of populations with high rates of vaccination, such as healthcare workers and likely their families, antibody tests don't provide a lot of value if your goal is to find out about background infection. The benefit of a nucleocapsid piece of the assay is that it reacts to infection, but not vaccination. So by having these two pieces of information, we can look at a number of different things. On the one hand, we can look and see even among vaccinated people if they've also been infected. So an infected individual would have a positive result for the spike protein and the nucleocapsid. And then we can also look just at vaccinated people. We would expect them to have at least a positive spike response. And in the context of waning antibody responses to vaccines, it will give us the ability to start looking into that as we go forward in time, see how many people start coming up negative in terms of their spike response as time goes forward. And just to give a few more insights on this, we did a sub-study in the healthcare worker study looking at actual continuous levels of antibody responses to the nucleocapsid. So the y-axis here is a nucleocapsid antibody response. These are people who were not previously infected to the best of our knowledge, but it was not a perfect definition. It was based on self-report and a prior antibody test result. So it is possible that there are a few individuals who had been previously infected, but simply didn't know about it, were asymptomatic. But you can see in the left-hand box plot, these are people who have not been vaccinated, and the right-hand side, these are people who have been vaccinated, and their nucleocapsid response is identical. And it's just demonstrating the point that vaccination does not induce a response to nucleocapsid. This is something that is specific to infection. And if we look on the right-hand side, these are unvaccinated and vaccinated individuals who we know to have had previous infection, and you can see that there's a clear difference in response, a bit of a wide distribution, but nucleocapsid is responding quite well and highly sensitive and specific to prior infection. So a couple of characteristics from this particular cohort that has participated in the seroprevalence studies recently that started in July, and I'm going to present results from July and September. The average age is about 45 in the index healthcare worker and the adult household member that lives with them. And then in terms of children in the household, we subdivided this into those greater than or equal to 12 or 6 to 11. We didn't enroll kids under 6 because of logistical reasons in terms of getting finger sticks. Their average ages are 14 and about 8.5. The index healthcare workers were predominantly female, about 85%, and their household adult members are predominantly male. And then there's about an equal split gender-wise in terms of kids. And we ask about previous infection, and it's roughly 5 to 10% in the index healthcare workers on adult household members. This is just based on self-report, so they had to have known that they were infected. And among the kids, it's quite a bit higher, as high as 20% or nearing 20% in the 12 to 17-year-olds, and about 12% in kids age 6 to 11. These are the results from the actual seroprevalence studies. And in the first 2 rows, these are the proportion of individuals who are reactive to the spike protein. So this could be due to either infection or vaccination. Among everyone, it was 80% in July and up to 87% in September. And those numbers are relatively consistent in the adults and in the kids. And I think the more interesting result is the second 2 rows. These present seroprevalence results from July and September, and this is reactivity to the nucleocapsid protein. And again, this is indicative of infection, regardless of vaccination. And the group of real interest here is the kids who are 12 and above. And these are kids who are eligible for vaccination. And it's looking like about 1 in 3 of them are demonstrating serological evidence of an infection in at least maybe the last 3 to 5 months. We don't know exactly how far back the antibody response goes reliably, but that's the early indication. And about 1 in 5 of the kids 6 to 11. So there's a fair amount of infection in kids, and these are results that are based on kids only being in school for about 2 weeks, based on the timing when the survey was deployed. How does this compare to other data from Minnesota? There are not a lot of other data from Minnesota, but the CDC is doing stuff from leftover blood samples in a clinical setting. And the arrows here indicate nucleocapsid reactivity percentages among kids 0 to 17 years of age. And their estimates back in December 2020 were about 13%. This is just as we were coming off our peak last year. And then by June 2021, that had gone up to about 16%. So our estimates are consistent with that in that they're higher, as you might expect, moving forward in time to July and September, as mitigation efforts were largely lifted and kids were getting back into fall sports starting in August and then back into the classroom in September. I was also just going to share in this population, since we're talking a lot about vaccinations today, vaccination rates and mandates. This is a population, at least in terms of the index healthcare workers, where mandates have been in place for many of, but not all of them. And the vaccination rates are quite high, about 95% to date. In the adult household members, it's slightly lower, but still over 90% and quite high. And interestingly, in the kids, it's over 70%, which is very encouraging. So again, this is not going to be representative vaccination rates in 12 and older kids in the general population. Almost certainly likely to be higher, and it's hovering over 70%. And then the younger kids are at this time still ineligible. And one final thing I want to share from the healthcare worker study, because it also has relevance to the university mandates and maybe some reasons that people are a bit hesitant among those who have not been vaccinated, has to do with previous infection. So if you start over on the left, these are the index healthcare workers, and the y-axis is prior infection percentage, And then blue bars are people who are vaccinated, and orange is not vaccinated. So as you might expect, vaccinated people are far less likely to have a history of infection. At least a lot of this is driven by recent history, but overall they're less likely to be infected. And there's a huge increase in the infection proportion among individuals not vaccinated. And this is consistent in the adult household members and in kids that are vaccine eligible age. So one caveat here is the temporality of these relationships is difficult to establish. And a lot of the infections actually probably came prior to the vaccination. We can't definitively determine that in all situations because quite often we just don't know the date of infection because it's based on serology or just a self-report. But either way you interpret it, it has, I think, important implications. On the one hand, to the degree that some of these vaccinations were before the infection, it simply demonstrates real-world effectiveness. But more and more what we're seeing in several different surveys is that people who are unvaccinated are much more likely to report prior infection. And I think the implication of that is that people believe that if they've already been infected, that the vaccine no longer does them any good. So why go through the burden of getting the vaccination? And I think that's largely what this slide is actually reflecting for the reasons previously stated vis-a-vis the study design. So keep that in the back of your mind as we move forward because it will come up again when we talk more about vaccine mandates. So switching gears over to vaccine mandates and specifically the University of Minnesota's COVID vaccine mandate survey that we conducted in September. Again, I want to acknowledge several key people who have been really influential in bringing this particular study together and essential funding from the OVPR's office to pull this together. So thanks very much to this group. And I'll note that maybe in the spring at some point in time, hopefully Dr. Ulrich will have a chance to present some of the vaccine hesitancy work that she's been doing, particularly in the healthcare worker study. She's really been a real leader in that space, and I appreciate all her efforts in that regard and look forward to seeing those data as they come together. I also wanted to mention the OMS team, the Office of Measurement and Services. I've never worked with that group before, but we put this survey together incredibly quickly, given various timelines, which we'll talk about a bit more in a second. And they were just outstanding level of professionalism and the capabilities that they have. So if you have not worked with this group before and you're doing survey work, I highly recommend reaching out to them and considering involving them. I'm not going to spend a lot of time on the history of vaccines, but I think it's worth saying a few things to put vaccine use and vaccine mandates in the broader context. So as I was reading about this, I was reminded that George Washington had actually mandated smallpox inoculations among constitutional soldiers. And that's because most of the deaths actually were not due to battlefield wounds, it was due to disease. I think this is a particularly interesting point when people talk about the freedoms that we have in this country, the freedom to choose, et cetera, particularly as it relates to vaccinations. It's important to remember that a lot of those freedoms were earned in part through measures that implemented public health approaches to make sure that we could secure various freedoms and move under a constitutional democracy. As early as 1827, the Boston public schools required smallpox vaccinations. So we have a long history of requiring kids to get vaccinated in our schools. And all 50 states at this moment in time require vaccinations for school attendance for at least 40 years. Although many states do have some exemptions, religious and philosophical exemptions. And I'll note that the state of Minnesota actually is one of those rare states or more rare states that has both religious exemptions and philosophical exemptions. So in the Minnesota context, we're very familiar with mandates, but we're also used to having some control and ability to circumvent the mandate and not get vaccinated if that is our particular choice. And I think that's important to remember, particularly in our specific university context. Do vaccines work, and do mandates more specifically work? Well, in terms of vaccinations, again, we have a long history with vaccination for a number of diseases that cause great population level burden and mortality. And through a number of very successful vaccination campaigns in the last century, many of these infections have all but disappeared. I use measles as one example here, because prior to 1963, there were up to 4 million infections annually in the United States, 48,000 hospitalizations, and 400 deaths. And measles has all but been removed, although there has been some resurgence in the last decade or two due to vaccine hesitancy in certain populations. But largely, we don't experience measles anymore. And I think the point about measles I like to raise is that the actual death rates were quite low, as is an argument made for COVID in many populations, that especially if you're young and healthy, the chance of death is fairly low. But that doesn't mean there's not a fair amount of suffering associated with the infections themselves. And we have to think about the other regarding behaviors in the context of very infectious diseases that can be easily transmitted. So it's not necessarily how it impacts oneself, but thinking about the broader society and what vaccination means for all of us together. I wanted to say one quick thing about the effectiveness of mandates in other contexts. As I've alluded to in the previous slides, mandates seem to be working well. In a more recent context, also in the context of a respiratory infection, these are data from California, where they instituted an influenza vaccination mandate for healthcare workers between 2017 and 2019. They did some interrupted time series analyses, basically looking at trends in vaccination rates in the blue line and inpatient influenza diagnoses. So basically patients of the healthcare workers who were vaccinated. And these rates were both quite stable. No real year-to-year change leading up to the institution of the policy. And in the years following that mandate, vaccination rates went up by about 10%. So not necessarily dramatic increase, but still quite meaningful. I think in absolute terms, it went from about 75% to 85% of people vaccinated. And the inpatient influenza diagnoses went down by a meaningful amount. So more people got vaccinated and fewer people ended up getting infected as a result of that. And I think this is one of many examples of how mandates can be helpful and reduce morbidity in the population. So, in summary, we know vaccine mandates work historically. They do seem to get more people vaccinated. They do seem to prevent infections. And in some contexts, they can have very dramatic effects in that regard. And they reduce complications of infections. So these things are all incredibly important. In the setting of COVID, however, we really have limited data, and we have very limited data in the university setting specifically. I think a lot of what we know historically will apply to COVID, but we just don't know. And in science, if you don't know, you can't assume. We've got to actually collect the data and make sure that those assumptions are correct. So, how many more people will actually get vaccinated in a particular setting if you institute a mandate, particularly in a university? How many infections will actually be prevented? And what I'm really curious to learn going forward in the future is to what degree do mandates actually reduce hospitalization and death? Because in the context of COVID, I think these are going to become the metrics that we really follow and have to be concerned about. More and more, it may be difficult to hope that infection rates themselves will drive down near zero. And instead, what we'll be left with is trying to make sure that we can mitigate any of the negative outcomes of infection. So in August, when it became clear that the university was going to institute some sort of requirement to get vaccinated or at least test once the full FDA approval was granted, we wanted to establish some sort of survey so we could get a baseline on mandate awareness, vaccination levels and reasons for vaccination, and also vaccination attitudes. So that was the goal. And as a reminder, right now, the requirements for students are largely what they've always been for vaccination. They have to fill out an immunization form, which would include COVID. There are some exceptions for religious or medical issues that can be filed. And for staff and faculty, the requirement is to attest to your vaccination status, and if you're unvaccinated, to comply with testing requirements. I'll note that it sounds like this is going to change soon, according to Dr. Oakes. It is not entirely clear when or how, but the Biden administration federal mandate is going to influence the University of Minnesota because we receive federal funding. So there'll probably be more teeth to the current mandate in terms of requiring various forms of proof of vaccination and/or testing. So more remains to be seen, and we're fortunate to have gotten a baseline on some of these issues before these things change and evolve. In terms of methods, it was a random survey sent out via email to 12,340 members of the university community. 6291 ended up participating, and it was a very brief questionnaire. So 20 questions total, but depending on how you responded, a maximum of 13 questions would be asked to any one individual. For those that aren't fully familiar with Minnesota geography and where our various campuses are, on the eastern borders, we have Duluth, the Twin Cities campus right here, and Rochester, and on the western border, there's Crookston up in the northwest part of the state, and then Morris in the west central part of the state, which incidentally is not too far from where I grew up, so I know that area well. A quick couple of notes on timeline. So in late August, the FDA fully approved the Pfizer vaccine. President Gabel sent an email basically saying change is coming in regard to the university's mandate requirements. The next day, Provost Croson announces attestation site is now open, directing people to go and attest. And our survey opened roughly a week later on September 2nd, coinciding with about the beginning of classes at most campuses. And the survey closed 2 weeks later on September 17th. And this was also the deadline for attestations to be due for faculty and staff. And immunization form completion was required for students by October 8th. So that's a rough timeline of when things happen. So the survey did open after full FDA approval of the Pfizer vaccination and after the university had indicated that people would need to attest, and it was open for roughly a 2-week window. A couple notes on sampling. For the Twin Cities and Duluth campuses, there are about 60,000 and 10,000 members of the community broadly. About 10% of those communities were sampled, and then about 50% actually agreed to participate. Crookston, Morris, and Rochester are presented separately because the scaling is difficult to put on the same access since they're smaller schools. And the one thing you'll note is that a much higher proportion of individuals in the orange bars were invited to participate relative to their total community size, which is represented in blue bars. The main reason for that is because the campuses are smaller. If we only had a 10% sampling rate, we'd essentially have no faculty and staff from those locations. So in that situation, 3/4 to 100% of them were actually invited, and therefore they slightly are overrepresented in the sample. So you can keep that in mind as we go through. Participation rates overall were quite good. I was very happy with them, generally about 50%, a little bit lower in Crookston where it was 49%, but most other campuses were at 50% or above. In terms of sampling by role, this again just shows the same numbers, but in a different light, looking at the number of faculty, students, and staff. So right here, this is faculty and staff. The students are on a different scale because there are far more students than there are faculty and staff. And about 15 to 20% of each of these groups were invited. So there's not dramatic over or underrepresentation by any one of these groups. Participation rates were remarkably high in the staff, among almost 70%, which is terrific, 62% in faculty, and then a bit lower in students, as we might expect. The average age of the sample was 27, 62% were female, and 6% of the actual sample was comprised of faculty members, and faculty represent 5% of the overall University of Minnesota community across all campuses. For staff, 23% of the sample was staff, and that's slightly overrepresented in terms of their contribution to the overall community. And for students, we had 71% in the sample, and they are 77% of the total UMN faculty, staff, student composition. This breaks down some descriptives by faculty, staff, and students, things that won't be terribly surprising. So faculty and staff are older than students by 20 to 30 years. There's not a lot of age variation by campus, but Crookston and the Twin Cities campuses do have slightly older age groups, and the gender distribution among faculty is roughly 50-50, tilted towards females among the staff and among students, and that was consistent across various campuses. So first, we had asked about mandate awareness, just are you aware of the mandate? And nearly everybody was aware, a very small number of individuals who had absolutely no awareness of the mandate at the time this survey went out, and that was pretty consistent across campuses, not a lot of variation there. It was also fairly consistent across student, faculty, and staff, so over 95% of student, faculty, or staff were aware of the mandate. The one driver of difference here, interestingly, was vaccination status. So individuals who were vaccinated were highly aware of the mandate. Unvaccinated individuals, slightly lower, around 85% were aware. Sort of interesting. And we asked if they actually read the mandate, and about 73% reported yes, and a quarter of them said no, they had not read the mandate yet. Again, this is reasonably consistent across campuses. I won't get into the specific numbers here, but it hovers around 70%, 75% had read the mandate. Far more staff and faculty than students had read the mandate. So real quick, I want to shoot out a very quick poll just to get people's guesses at what the vaccination rates across campus actually are at the University of Minnesota. So there should be a poll launched now. Give it about 5 more seconds, 70% response. Okay. All right, so in terms of percentage of students, the majority of people would say 90% of students have been vaccinated, but about 50% say it's somewhere in the 70 to 80%, and a smaller proportion, 60%. There seems to be more belief that vaccination rates will be higher among staff members, so 44% say that 90% are vaccinated, and then another about 55%, I think it's in the 70 to 80%, and everyone is guessing even higher vaccination rates among the faculty. So let's take a look. So excellent guesses. Overall, 90% reporting vaccination, and that's fairly consistent across most campuses, but Crookston is clearly the outlier. Under 70% report previous vaccination. And I think this is really important in terms of how we think about response rates and what it means, because to me, this is suggesting that this is not a survey that was simply answered by people who got vaccinated. There could be some bias in that direction, but clearly unvaccinated people responded to the survey, and I have more to say about that towards the end. The vaccination rates by role, your poll results were spot on. Faculty are the most vaccinated group, followed by staff and by students, and that largely probably follows age trends. This is just showing by campus and role. So the big takeaway from this slide that I'll point out is students at the Crookston campus were really what drove the low vaccination rate data in that particular group. staff and faculty were still reasonably highly vaccinated. And this shows trends by age groups. So the youngest age group, which is where the largest proportion of the sample and is predominantly students, about 86% vaccination rate in the younger groups. It quickly jumps up to 90. And as you get into the older age groups, it's 97% to 100% overall. So age is a key driver of vaccination. I'm going to skip through this poll in the interest of time and just get right into some data on the actual influence of the mandate among vaccinated individuals. So this is among all people who were actually vaccinated. We simply asked about the timing of it to see how many had gotten vaccinated in the roughly 2-week window between the requirement and when the survey opened. And about 3% said they got vaccinated after the mandate. And among those, that's a very small number, but among those, 3 out of 4 said that it was because of the mandate. So another key question we wanted to ask was, among the total university community, what is the percentage of vaccination due to the mandate? So this is including even people who are unvaccinated, and it's really getting at the question to some degree, at this point in time, how many people have actually changed their decision or taken action because of the mandate? And that really comes down to people in these two areas. They're the people that said, yes, I'm already vaccinated because of the mandate. And then, yes, I'm going to get vaccinated. I'm not vaccinated yet, but I'm going to because of the mandate. And there's a small percentage of unsure individuals. So if you apply that rate loosely, and this is not done with appropriate weighting yet, but the weighting is not going to influence this probably in a meaningful way, and it will likely decrease this number. That maybe means around 2,000 people in the university community, at least to date, have become vaccinated because of the mandate. That's not saying anything about what might happen as we move forward in time. This presents the exact same information by campus, and the big take-home message is that it's moving people most where vaccination rates were lowest to begin with, particularly in Crookston, not so much in the Twin Cities, where we had higher vaccination rates to begin with. Similar finding if you look by faculty, staff, and students. So the big take home here is the biggest area for movement is probably among students and not so much among faculty and staff. And then we looked at this by previous infection status. And again, the biggest area for movement, these people who are vaccinated or going to be vaccinated because of the vaccine, seems to be in people who were previously infected. And this is a group that was less likely to be vaccinated at baseline. So there's more room for movement, and therefore you see more movement. I'm going to skip through this slide in the interest of time. Very briefly, this shows mandate support by vaccination status. So the blue bars on the left are people who are supportive, yellow in the middle, they're neither supportive or unsupportive. And then on the right-hand side, these are people who are not supportive of the mandate. And as you might expect, if you're vaccinated, you're very supportive. If you're unvaccinated, you're not supportive. Not very surprising. Good to show that. It's consistent by campus with the lowest level of support in Crookston. And it's reasonably consistent by role, but again, lowest support among students. And there are some open-ended comments that really kind of speak to maybe where some of this is coming from. In terms of change in personal risk, a majority of people at most campuses feel that the mandate lowers their personal risk of related to COVID. So it seems to be shifting attitudes and at least perceptions of risk in most places. Again, in Crookston, not so much. Most people think that it made no difference. And it's fairly consistent by role as well. So this is faculty, staff, and students in terms of how much your personal risk has changed. Faculty and staff think predominantly that it lowered their risk. Students do too, but to a lesser degree. A couple more data slides from the survey. If we ask among those vaccinated why, it's largely to protect themselves and others, although a large chunk said doctor recommendation, which highlights the role of the healthcare professionals in driving vaccination, potentially, at least in a university setting. And if we ask about reasons for not getting vaccinated, the number one reason is vaccine safety concerns. And people could respond to multiple, and we included all of that. Many of these, I think, areas and groups, people with vaccine safety concerns, may be hard to move in the short term. I'm not entirely sure. Religious reasons, probably hard to move in the short term. And that could be said among a lot of these groups. The one group may be individuals who are predominantly not vaccinated, again, because of previous infection. And if we can educate that previous infection is not necessarily a guarantee that you will have full, durable, long-term immunity, we may be able to move that group, and that could inform strategies moving forward. So the final thing I wanted to mention was the open-ended comments was the big surprise in all this. I really did not expect a lot of open-ended comments from this, and 30% of the sample actually gave open-ended comments, and many of them were quite lengthy. It varied by campus, and Crookston actually had the highest rate of open-ended comments. And a lot of those comments tended to be from folks who were not very supportive of the mandate. And that was generally true of the open-ended comments, that I would say a majority were coming from folks who were not supportive. These are just some additional characteristics. For example, unvaccinated people are much more likely to have provided a comment. So we're getting real feedback from folks, and particularly from folks that don't necessarily like or support the mandate. And this is showing that as well. Among people unsupportive of the mandate, 45% of them, almost half, provided some sort of comment. This is what they looked like. So here were some very common examples of open-ended comments. I would like the process to require more information, basically prevent people from lying. So these people are supportive and they want more proof. These people are not supportive. There were a lot of my body, my choice, that exact phrase throughout, and various derivations of this response, that it should be a personal choice. And then actually a lot of responses about faculty and staff should be required to be vaccinated. It's not fair to require students and not faculty and staff. These were some more unique responses, but still, I think, represented things that were not singular. People were responding in ways quite similar to each of these. So something about FDA approval in cigarettes, which I got a kick out of. We absolutely cannot return to the treachery of online learning. It's a big part of keeping athletics going, so it's a great idea. And this last point's a good one. Why would we require online people who are never on campus to get a vaccination if this is about community safety? So we'll maybe have to do some thinking about that. Then there's some misinformation, disinformation. The first one talking about variants and how the vaccines will not work against variants, so it's a waste of time. That is not true based on the evidence to date. The second one, it's an invasion of privacy and rights, and talking about how the vaccine is a bioweapon made to kill people, and the UMN is complicit in this act. The reason I show this slide is because of the prevalence of misinformation and disinformation. And these are responses from our colleagues and students. They're people that we've hired, tenured, and admitted to our programs. So I don't see these as coming from people who are very fringe and off the grid. These are real concerns by people we're working with and educating, and we need to take it seriously and understand it better and be able to communicate effectively and patiently with this group of individuals, because these comments were not rare. A comment about other regarding behavior, John Stuart Mill quotes, a lot of thank yous I wanted to acknowledge because there was a lot of support that came through in the comments as well. And then just to conclude, there are a lot of future logistics that are going to have to be thought about. A lot of people want stronger mandates, but what does that mean? And what is proof? Is a vaccine card enough? And how easily can it be falsified? Are we going to go to bioassays to try and prove that people are vaccinated? And what will that cost be? And who will do the actual work? How will this be handled in terms of tenure? Can you actually force a tenured faculty to get vaccinated? There's a lot of questions around that. And there are at least 25,000 non-university employees on campus in terms of construction services and food services. How do we handle these individuals? Because they don't have to play by our rules necessarily. And then finally, the last slide, a couple of key summary points. The mandate, I think, has almost certainly led early on to more vaccination. We don't know if it's actually going to reduce hospitalizations and deaths, and I think that's a key metric to get more insights on. And the vaccination rates at University of Minnesota are generally quite high, so it's a low-risk environment and the benefits could be marginal. We need to take that into consideration in our thinking. We'll have to think a bit about the potential limits then and the influence the mandate can have. How and where do we target most efficiently to really get the most out of the mandate? And then I think I'll just conclude by saying a notable number of people do have concerns. And again, I think we really need to be listening carefully and patiently in a non-condescending and patronizing way to understand where people are coming from, get the truth and the real information out there to ultimately increase vaccination rates and safety in our community. So I'll stop there and thank you very much. Look forward to the discussion.
Thank you, Ryan. That was excellent. If you could use the raised hand function, we'd be happy to call on you for a question. Ryan, who are the, while people are generating their questions, who are the people, the stakeholders that you'll be working with to disseminate this information at the university?
First and foremost with Michael Oakes as the Vice President for Research, and he's communicating frequently with the higher level leadership at the university as a starting point. And I'm curious to get feedback from my colleagues within the division, faculty, staff, and students from School of Public Health as to the types of questions they might like to see asked or approaches taken in the future if we try and do essentially another survey sampling people in possibly December to see how many more individuals have been vaccinated and ask about how that relates to the mandate versus other reasons.
Hi, Liz.
Ryan, do you have any insight about the mask mandate versus the vaccination mandate? I mean, how those kind of go hand in hand, or is there some potential for the vaccine mandates to influence the masking mandates?
It's a great question. The short answer is I don't. There were a lot of comments about masks, generally negative ones in the open-ended responses, but we didn't ask anything specific about masking other than among people unvaccinated. It is, probably 1 in 3 people say the reason they're not vaccinated is that they're simply going to mask. But in terms of will we lift the masking mandate once we get above a certain vaccination rate, I don't know. I would imagine that in time the mask mandate will lift, but I have absolutely no insight as to when or how that decision would be made.
Diane.
Hi, Ryan. Can you hear me?
Yeah, I can. Hi, Diane.
Thanks for a great presentation. I wanted to share that the numbers that I had from Tracy Kane at the end of September for the School of Public Health, not from your survey, but from the actual attestation rates were, I think, and you may have even updated numbers, were about 97% of faculty and staff had actually completed the form. And of those, close to 99% were vaccinated. So very, very high rates. And I don't know if you had survey results from the School of Public Health, like if you were able to look by School of Public Health. That was one of my questions. And I'm just gonna ask my second one. So the rates across the university seem really, really high, according to this survey. Are we being too strict in some of the things that we're doing in terms of social distancing, masking you talked about before, not having, limiting number of people in our meeting rooms? I don't know if you have thoughts on that, or perhaps not being strict enough.
Yeah, great questions, and thanks for sharing the SPH rates. I think a lot of people were concerned about the rates we were getting from the attestations early on, because the assumption was it's all the people who are vaccinated who are quickly just tuning in to say that I'm vaccinated, and they're going to be overrepresented. And that does seem to be the case, although it was not grossly overrepresented, representative, because a large proportion were vaccinated. I don't have access to SPH level information. I could look into that. There, in the background, there might be information on what unit people were in, but I don't have access to that at the moment. We were very careful. I wanted to make sure that there was a pretty good firewall in between personal identification and the survey results. So I really have no ability to get at that, but I could look into it and see if we could at least look SPH wide. In terms of being too strict, my opinion on the mandate, and I've had several internal conversations with a few people that are tuned in today, and I think I'm a little out of the mainstream probably in a school of public health. I don't know that for sure. I'm not enthusiastic about hard mandates at this moment in time. I think they work. I have that they will work for COVID. I know that they work in other contexts, but in other contexts, we've had a lot longer period of time to adapt to them and for people to get used to the idea and slowly come to terms with it and not feel quite so forced to do it. So I prefer an approach that maybe is targeting mandates starting next year and not this year. A lot of people disagree with that, and that's obviously not the direction that the university is going to be going, but I tend to be a little bit more middle of the road. So I would say that, yes, we might be being a little bit too strict. But I'm also very sympathetic to the fact that there are a lot of people very worried. And when you're worried about, discomfort on a mask on one side of the spectrum, or illegitimate safety concerns about the vaccines, I don't think that those should have equal weight to somebody who's concerned about dying because they have an underlying medical condition or they live with somebody who does. So I'm fine erring on the side of too strict at this particular point in time. But I think over the course of the next year, many measures are probably going to have to be walked back and lessened, and we should all be prepared for how we're going to handle that. So maybe that's where I'll stop on that. And the last thing I wanted to say about this too, you reminded me that now that we're probably going to move into a phase where there's stricter requirements for proof of vaccination, we'll actually be able to do a lot of careful looking at how honest people were in the initial reporting. And that will be really interesting just in terms of the value of using attestations to inform real background vaccination rates.
So just a few notes from the chat. Sarah has mentioned that she's spoken to students about this attestation process and how there might be some misreporting because they're not being required to prove anything. Lynn Steffen would like to know if you know the percentage of breakthrough cases at the university.
I don't know the percentage. That's a great question, though. I have no idea. And I'm not really sure how carefully we're tracking it, to be honest.
Steve.
Yeah, Ryan, thanks so much for a great presentation. I feel like we're getting a bit of mixed messages about the protection that comes after infection versus the protection that comes after vaccination, with some recent papers suggesting that sort of the combination of those two things really boosts protection. That's one question. And then the second follow-up is with the reports of decreasing effectiveness of the vaccination, I always wonder, is the vaccine actually getting less effective, or is it just being compared to a group that is more predominantly infected previously due to natural infection?
Yeah, I think those are great questions and points. In terms of natural infection and mixed messaging, I agree. When people ask me about this, I say, I have no doubt that natural infection generates natural immunity and gives you some protection, but it's probably highly variable relative to the vaccines. And it's a really hard question for us to answer clearly in the data, because all of those data are based on observational data, which can be very complicated and confounding, and we're still awaiting rigorous studies on this question. For the vaccination, we have really well-designed controlled studies where we know exactly what the intervention is, what the placebo group is, and the effectiveness there. So, you know, it's just clear that vaccinations work. Prior infection probably does, but for whom, we don't really know. I think another outlying question is, if you had a really bad infection and you were hospitalized, how protective is that? Are you subject to higher risk for that bad of an outcome or worse, or do you maybe have better protection going forward? And there's a lot to be learned there. And then, sorry, I already lost track of the second part of your question there, because the first part.
Thanks very much. That was a good answer to the first and very helpful. The second question was just that we're hearing about declining effectiveness of the vaccination, but the comparison group is a group that is increasingly infected through natural stuff. And, you know, even just today with the kids, the young kids, and of course the vaccine is 90% effective because the young kids hadn't been infected before, the unvaccinated ones as much, you know. So I just wonder whether vaccine effectiveness is actually declining or the comparison group is getting better.
Yeah, I think it's part the comparison group getting better. And there were some nice presentations from Israeli data, and I think that you and I had actually chatted about that a while back. Some of the early evidence about declining vaccine effectiveness was actually just confounding by age in the observational data. If you actually standardized by age and took away that confounding, the vaccine effectiveness remained very high in all age groups. So I don't think it's declining to the degree that people think so far.
Ryan, would you be able to stay 5 to 10 minutes extra?
Yeah,
and
definitely.
For those of you who need to leave because we are already a minute past the hour, thank you for coming. We hope to see you again. Before we get to Mary's question, I just want to make a comment from Nazreen, which was actually great comments, but also a question. Will you be returning results to the survey participants?
It's a great question. We have not thought about that yet. It's kind of a matter of time and resources. In the short term, we don't have plans to do it. We will work to publish these data, and in that regard, it would be returned to anybody who wanted to avail themselves of it. Generally in this setting and with the healthcare worker study, what I've done is after something is published, I make them aware specifically so that they could go to that publication. So in the long term, yes, we are likely to do that. In the short term, no.
Mary.
Hi, I was just curious. I saw a newspaper headline yesterday that said that people who are unvaccinated can expect to get COVID every 16 to 17 months or something like that. So based on some of the responses that you got on your survey, do you think if that information turns out to be true, do you think that it might influence more of the people who are unvaccinated because they've gotten COVID to actually get vaccinated?
Yeah, that's a great question. Hadn't thought about that at all. I think it's quite likely that the specter of reinfection could cause a lot of people to move, particularly people with really bad infections that just don't want to go through it again. I think we're going to need better data on how likely is it that you'll get reinfected, what's the timeline, and I'm particularly interested in if you had a mild infection, does that mean your second infection is mild, or does it get worse? And the same for severe infections. And that will probably be really important in that particular regard. So great question, Mary. Sorry I can't answer it more clearly. I do think it will be influential, but stand by.
Yeah, thank you.
It looks like Jim has the last question.
Yeah, really great seminar, Ryan. This is more of a comment, which is, organizations like the U that institute mandates. And one of the things I'm starting to sort of realize is when you institute these mandates, then for the folks that don't comply, that requires a fair amount of time of some people at the university to deal with that. So I know at the faculty level, the president has now established a vaccine attestation advisory committee that has to meet and look one by one at all of the faculty who haven't applied with an attestation and decide on disciplinary action. And so that's going to be time for, a segment of people who have to review all of those cases one by one. And the same is, I think, true at the staff level.
That's interesting. I wasn't even aware that there was an advisory panel coming together, but this is a great point. And it's been one of my concerns is if we're already at really high vaccination rates, how much benefit are we going to get by moving another 2 to 3% or a couple thousand people towards vaccination in the next 6 months? What will that translate into in terms of real infections and hospitalizations and deaths? And then what will be the burden in terms of cost and time commitment from our faculty, staff, and students to enforce it? Really complicated questions, and I don't have great answers to them, but we're all going to have to put our heads together in the course of the next year to figure this out. I think, the more I tend to think that a lot of people will move towards vaccination as we get more data and better data on the safety and efficacy of it. And we have more time to dispel the enormous amount of rumors that are out there. It's surprising the number of new rumors and disinformation I get asked about on a weekly basis, where I haven't even heard of it. And then I have to dedicate a bunch of time to looking into it to see if it's legitimate and serious. But usually with most people who have been hesitant or have had a family member who's hesitant that I've spoken to, when you kind of go through some of the most common pieces of misinformation or disinformation, which usually are that the vaccine is really unsafe or that it will cause potentially infertility, which there's no evidence to support and evidence against actually, as they work their way through understanding that information, they become much more willing to get vaccinated. And I know a number of people personally who have kind of gone through this process and decided to actually change their mind and become vaccinated. So I think a lot of people will get there. It's just going to take time.
Ryan, actually, if you don't mind, we did have one additional question. Eleanor is asking, I'm going to put a little background to this, because you said that some of your results were a part of the fact that the university already had high background vaccination rates. She's wondering if you have any data from other institutions or communities looking at knowing of their vaccine mandates and whether it changed in different ways from our own data.
Yeah, that's a great question. I don't have data at this moment. There has been some discussion about trying to get other institutions, like institutions, for example, other Big Ten institutions, to implement the same survey, essentially, so that we can compare across different contexts. I know Michael Oakes has been thinking about this, communicating with colleagues in other places to see if there's interest. So we may go in that direction. It's a bit TBD.
Thank you so much. Did you see Heather's comment?
Yeah.
I was just involved with, that went through the faculty senate and the provost, trying to make a path for what to do when faculty don't do the attestation. And while the numbers seem low, there are these power dynamics in the university, and we should be sensitive to them.
And Heather, I think you were also making the case that it's a vaccine mandate or agreeing to be tested regularly. Is that the other point you made?
Yeah, I think, and I'm sorry, I was late today, so I don't know how much that was covered, but, I do feel like we're underplaying that part. Like, if we could have rigorous testing for those who don't want to get vaccinated, that's okay too. And I think that should be a tactic we're taking.
Yeah, I completely agree. I love the idea of, I've been saying for a long time that we need far more testing scaled up in a more meaningful way. I wish the Genome Center's proposal would have been implemented in a way that makes it easier to get testing. And that could be a very effective way of allowing people to, exercise their choice to not get vaccinated at this point in time, but keep the university community safe.
Well, thank you again, Ryan. Thank you for the extra time. And we'll see the rest of you back next week. Goodbye, everyone.
Thanks, everyone. Bye.